Imagine it's 95 degrees outside.
Right.
Oh, just absolute brutal summer heat.
Exactly. It is the absolute middle of summer. The humidity is just suffocating. And you notice a high school student walking down the street wearing a heavy, long-sleeved winter hoodie.
Which is, I mean, you'd probably think they're crazy.
Right? Your first instinct, probably like most people, might be that it's just a strange teenage fashion choice. Maybe they were just trying to look cool.
Yeah, kids do weird things with fashion all the time.
But according to a fascinating new briefing document we are diving into today, for 1% to 2% of students sitting in classrooms right now, that heavy hoodie isn't a fashion statement at all. It's camouflage.
It's a deliberate shield.
Right.
They are actively hiding a physical toll that most of their peers, and often, even their own parents, know absolutely nothing about. Welcome to today's deep dive. We are analyzing a briefing from MentalSpace School. And at a quick glance, the document looks like a very high-level overview of K-12 mental health infrastructure in the state of Georgia.
Yeah, lots of policy talk at first.
Exactly. But when you get past that executive summary,
Yeah.
the core of this material focuses on a deeply misunderstood, just incredibly hidden struggle.
It really is hiding in plain sight.
It is. So today we are exploring where the medical community draws the line between what society brushes off as a simple bad habit and what is actually a severe DSM-5 medical diagnosis.
Which is a huge distinction.
Right. We're going to unpack the strange ways the human brain seeks automatic emotional regulation. And we'll look at how schools are being forced to radically change their approach to mental health just to keep these kids from falling through the cracks.
And to really understand why a completely new approach is necessary here, we have to look closely at the specific condition the briefing highlights.
Let's get into it. What exactly is the condition?
So the medical umbrella term is BFRBs. That stands for body-focused repetitive behaviors.
Body-focused repetitive behaviors. Okay.
Right. And the document specifically centers on two of the most prevalent forms of this. First is trichotillomania, which is a hair-pulling disorder. Okay.
And the second is excoriation disorder, which is a severe skin-picking disorder.
I want to pause right there, actually, because I think a lot of people hearing hair pulling or skin picking might immediately roll their eyes or just, minimize it entirely.
Oh, absolutely. They dismiss it.
Right. They might think of, picking at a hangnail during a boring meeting or maybe chewing on a lip when they're nervous. I mean, we all have those little background noises in our operating systems, right?
We do, yeah.
So I guess my question is, how does a clinician separate a harmless habit from a full-blown BFRB? Like, what makes it an actual DSM-5 diagnosis?
Well, the clinical distinction is actually quite severe. You are not just talking about casually picking a hangnail here.
Right.
To meet the criteria for a BFRB in the DSM-5, a clinician is looking for 3 strict, non-negotiable signs.
Okay, what's the first one?
First, there must be recurrent pulling or picking despite repeated attempts to stop.
Despite repeated attempts.
Exactly. That phrase, despite repeated attempts, is the critical marker here. It signifies a fundamental loss of control.
Oh, wow.
Yeah. The person wants to stop, they try to stop, and they simply cannot.
So the intent to stop is there, but the execution just entirely fails.
Right.
What are the other 2 criteria then?
The second criterion is noticeable physical effects. We're talking about significant visible damage.
Like what kind of damage?
Like large bald patches on the scalp.
Oh.
Or the complete absence of eyelashes or eyebrows.
Really? Complete absence.
Yes. Or permanent scarring on the arms and face. Or even chronic open wounds that do not heal because the tissue is just constantly being reopened.
Oh, man. That is intense.
It is. And the third clinical sign is significant distress or functional impairment. So the behavior has to be actively destroying their quality of life.
Which, I mean, that goes right back to the student in the hoodie, right? If you have severe scarring on your arms or large bald patches, you are spending an exhausting amount of mental energy just trying to exist in a public high school without being noticed. Oh, the camouflage requires so much energy. The briefing emphasizes how incredibly skilled these students become at hiding the physical damage. It literally becomes a daily high-stakes operation for them.
I can't even imagine that kind of pressure at that age.
Right. They use heavy foundation to cover picking scars. They use very strategic, heavily sprayed hairstyles to cover bald spots on the crown of their head.
Or they wear those thick hoodies in the middle of a heat wave.
Exactly. And because the behavior itself is often deeply private or even completely unconscious, they aren't doing this in the middle of the cafeteria where people can see.
So it's all happening behind closed doors.
Ugh.
But the document mentions that school staff, rather than parents, are frequently the first adults to uncover this.
Yeah, that's a really interesting point.
Why is that?
Mm.
I would assume a parent living in the exact same house would be the first to know something is wrong.
You would think so, but parents often assume the hair loss is a medical issue, maybe like a vitamin deficiency. Or they think the skin picking is just a really severe case of adolescent acne.
Oh, I see. They misdiagnose it themselves.
Right. But a school nurse sees the pattern. A nurse might be treating a recurring staph infection on a student's arm and suddenly notice the wounds are entirely self-inflicted.
Wow.
Or a physical education teacher might notice a student absolutely refusing to change in the locker room or refusing to participate in swimming.
Because that would expose the bald patches or the scars.
Exactly. They are the frontline observers of the camouflage failing.
But because it is so hidden, the moment an adult finally sees the damage, the immediate reaction isn't usually, scientific curiosity.
No, it's usually just pure shock.
Right. And that leads to a massive, pervasive misunderstanding. I actually want to push back on behalf of anyone listening right now who might be struggling to empathize with this.
Go for it.
Logically, if someone is literally pulling their own eyelashes out or creating painful open wounds on their skin, why doesn't the pain snap them out of it?
That's a fair question.
Right. Why isn't that physical evidence enough of a wake-up call to just employ some basic willpower and force themselves to stop?
It is the most common reaction people have, and it is entirely wrong.
Really? Entirely wrong?
Entirely. Relying on willpower to stop a BFRB is as clinically useless as relying on willpower to stop a severe asthma attack.
That's a strong comparison.
But it's true. Telling someone to just breathe normally during an asthma attack ignores the biological mechanism of what is happening in their lungs.
Okay.
So telling a student to just stop picking completely misunderstands the neurological function of a body-focused repetitive behavior.
So what is the mechanism then? If it's not a choice and it's not just a bad habit, what is the brain actually doing?
It all comes down to emotional regulation.
Emotional regulation.
Yes. Let's look at the neurobiology of what actually happens. When a student is experiencing overwhelming internal stimuli, whether that is severe anxiety, sensory overload, or even intense understimulation like extreme boredom, their nervous system is essentially dysregulated.
Right, they're out of balance.
Exactly. The brain desperately wants to return to a baseline state of calm. And through complex behavioral conditioning, the brain learns that the very specific, localized physical sensation of pulling a hair or picking at the skin provides an immediate, soothing sensory input.
I am really trying to wrap my head around how pain can be soothing. That seems so counterintuitive.
I know. Think of it like a thermostat that has been wired backward.
A backwards thermostat.
Yeah. Usually when a room gets too hot, the air conditioning kicks on to cool things down. In a dysregulated nervous system facing anxiety, the room is getting too hot.
Okay, I'm with you.
The brain triggers the picking or pulling behavior as its version of turning on the AC. The slight pain, or just the sensory feedback of the action, triggers a localized release of endorphins or dopamine.
Oh, wow. So it actually releases dopamine.
It does. It essentially tricks the nervous system into self-soothing. The system is trying to fix the problem of anxiety, but the backward wiring is causing physical damage to the body.
And because it works, because that tiny release of dopamine actually does momentarily soothe the anxiety, the brain reinforces the habit.
Heavily reinforces it, to the point where it becomes entirely automatic.
Automatic, like they aren't even thinking about it.
The individual often have no conscious awareness that they are even doing it until the damage is already done.
That is wild.
A student could be sitting there, intensely focused on reading a history textbook, and their hand is just automatically scanning their scalp, feeling for a specific coarse hair, and pulling it. They are completely on autopilot.
Which means when a well-meaning parent or teacher discovers the bald spot and says, just use your willpower, snap a rubber band on your wrist, and stop doing this to yourself, they are attacking an unconscious neurological loop with a conscious demand.
Exactly. It's totally mismatched.
What is the actual fallout of that approach? I imagine it doesn't go well.
The fallout is a catastrophic increase in symptoms.
Oh, so it actually makes it worse.
Much worse. When an adult demands willpower and the student inevitably fails because, willpower cannot override an unconscious nervous system response indefinitely, the student feels a crushing wave of shame.
Oh, man. They just feel like a total failure.
They feel broken. And shame causes anxiety.
Right. And anxiety is the trigger.
Precisely. The shame spikes their anxiety levels. And since anxiety is the primary trigger that causes the thermostat to overheat in the first place, the brain automatically responds to this new anxiety by, well, pulling more hair or picking more skin to soothe it.
So the adult's demand for willpower literally throws gasoline on the fire.
It really does. It drives the behavior further underground, the student isolates themselves even more, and the whole cycle just intensifies.
If you are listening to this right now and you have ever felt that immense wave of guilt after trying and failing to break a simple bad habit like biting your nails or hitting the snooze button, imagine multiplying that shame by 100.
It's a really heavy burden for a kid.
Imagine trying to break a habit you don't even know you are doing until you see blood on your hands. We cannot just leave a kid in that cycle. So, if snapping a rubber band and yelling, "just stop," makes it worse, how do you actually fix a backward thermostat?
You have to rewire it.
Rewire it.
Yeah. And that requires pivoting away from layperson advice and utilizing highly specific, evidence-based clinical interventions. The briefing document outlines the clinical blueprint for this, focusing heavily on habit reversal training, or HRT.
Habit reversal training. Reading through the mechanics of HRT, the analogy that kept coming to my mind was trying to change the tracks on a runaway train.
I like that. How so?
Well, if the BFRB is the train, it is barreling down the track completely on autopilot. You can't just stand in front of a moving train and yell, "stop."
No, you'll just get run over.
Right. You will get run over.
Yeah.
That is the willpower myth right there. To actually fix the problem, first you have to notice that the train is moving, and then you have to intentionally pull a lever to switch it onto a completely different, safer track.
That is an excellent way to conceptualize it, actually. HRT is entirely about disrupting that automatic momentum.
So where do you even start with that?
The very first phase of the treatment is purely about awareness. Because the behavior is unconscious, the therapist has to teach the individual to recognize the specific physical sensations that happen fractions of a second before the picking or pulling occurs.
Before it occurs.
Right. In clinical terms, this is called the premonitory urge.
The premonitory urge. Okay, what does that actually feel like? How do you train a teenager to notice something they've successfully ignored for years?
It is highly individualized.
Like it changes from person to person.
Exactly. For one person, it might be a subtle tingling in the fingertips. For another, it might be a specific kind of tightness in the scalp, or even a visual fixation on a perceived imperfection in the mirror.
So they have to really tune in to their own body.
Yes. Therapists will often have patients keep meticulous logs of their environment, their mood, and their physical sensations every single time they engage in the behavior. They are essentially learning to spot the train before it leaves the station.
Okay, so they finally recognize the urge. The train is firing up its engines. What is the equivalent of pulling the lever to change the tracks?
That is the second phase. Training a competing response.
A competing response.
What is that? It's a deliberate physical action that is completely incompatible with the BFRB. It has to be something that makes the pulling or picking physically impossible, and it usually involves isometric muscle tension.
Give me a specific scenario of what that looks like in practice.
Okay. Let's say a student's urge is triggered while they're sitting at their desk in math class.
Right.
They feel that familiar tingling in their hand and the urge to pull their hair spikes. The moment they feel that urge, they deploy the competing response. They might tightly clench their fists, or they might press their arms rigidly against the sides of their body, or even just sit directly on their hands.
Oh, because you literally cannot pull your hair if your hands are firmly anchored under your own body weight.
Exactly. You physically can't. And they hold that tension for a specific duration, usually a full minute, or until the urge completely passes.
That is brilliant.
The genius of this is twofold, really. First, it physically prevents the damage. Second, the act of clenching the muscles provides a different kind of localized sensory input to the brain.
So it still gives the brain that feedback it's craving.
Yes. It gives the nervous system a surge of feedback that helps regulate the anxiety, but it does so without causing any harm. The brain slowly learns a new, safer way to cool down the thermostat.
It is essentially biohacking the habit loop. I love that. But the briefing also heavily emphasizes something called comprehensive behavioral treatment, or COMB.
Yes, COMB is fantastic.
How does that differ from the HRT process you just described?
So HRT is great for the motor response, the actual physical movement of the hands. But COMB zooms out to look at the entire ecosystem surrounding the behavior.
The ecosystem.
Right. COMB acknowledges that the train isn't just running on one track. There are sensory, emotional, cognitive, motor, and environmental factors all playing a role.
What do you mean by environmental factors? Like literally the physical room they are in?
Yes, place factors are massive. A comb therapist will map out the student's entire day. Like, does the picking only happen when they're standing under the harsh fluorescent lights of their bathroom mirror?
Oh, wow.
If so, the intervention might be as simple as changing the light bulbs to a dimmer setting or putting a physical barrier over the mirror during high anxiety times of the day.
This is so practical.
It is. And if the trigger is sensory, like the brain obsessively seeking the feeling of a coarse hair, the therapist might introduce a textured object for the student to manipulate instead.
So it is highly, meticulously personalized to the exact triggers of the individual. I also noticed the document mentions cognitive behavioral therapy, CBT, and sometimes even SSRI medications as adjuncts.
Those are crucial when the underlying driver is a severe generalized anxiety disorder or depression. A licensed clinician might use CBT to restructure the perfectionist thought patterns that lead to skin picking, while an SSRI helps lower the overall baseline temperature of that internal thermostat.
Now, I want to talk about the stakes here.
Okay.
Why is it so critical that schools and parents understand the need for these specific clinical interventions? Like, what happens if we just continue to ignore it or hope they magically grow out of it?
The stakes are incredibly high, honestly, and the medical complications are severe. The good news is that BFRBs respond wonderfully to HRT and comb. Patients experience highly meaningful reductions in symptoms.
But if they don't get that treatment?
If left untreated, BFRBs do not magically vanish when a teenager turns 18. They persist and they intensify into adulthood.
Yeah, the briefing gets pretty graphic about the long-term reality of that. We're talking about permanent, irreversible scarring that requires surgical dermatology to address.
Yes.
We are talking about chronic, severe staph infections from open wounds. The source even details massive dental problems resulting from nail-biting variants.
The dental stuff is really rough.
Right, where the constant years-long pressure physically misaligns the teeth, it fractures the enamel and damages the jaw joint.
The physical toll is devastating, but I would argue the psychological toll is worse. The chronic shame, the avoidance of intimacy, the constant fear of being found out, it dictates the entire trajectory of their adult lives. Early intervention is not just helpful, it is critical.
But this brings us to a massive logistical wall. You just described highly specialized intensive clinical therapies. You need a trained clinician to map out a teenager's entire sensory, cognitive, and environmental ecosystem.
It's a lot of work.
It is. How in the world is a 14-year-old supposed to access that kind of care during a regular school day?
That's the million-dollar question.
I mean, they are hiding the symptoms under a hoodie during third-period math. They can't exactly drive themselves to a specialized psychiatric clinic every Tuesday at noon.
This is the exact bottleneck that traditional community mental health models completely fail to solve.
Right.
And it is the gap that MentalSpace School is systematically addressing in Georgia right now.
Okay, so how are they doing it?
They are shifting the paradigm from referring a student out to a clinic to building the clinic directly inside the school's ecosystem.
Looking at their model in the briefing, it is a really fascinating approach to operationalizing this care. They aren't just handing a stressed-out school counselor a pamphlet and a list of phone numbers with 6-month wait lists.
No, the traditional waitlist model is completely obsolete here. MentalSpace provides same-day teletherapy and immediate crisis intervention.
Same day. That's incredible.
It is. They assign dedicated, diverse, culturally competent therapist teams to specific schools. This means the students are actually building a relationship with a consistent clinical team that understands the specific dynamics of their community.
And let's talk about the impact of the acronyms listed in the source, because it is really easy to gloss over them, but they are the entire reason this works. The document stresses that MentalSpace is fully HIPAA and FERPA compliant.
That is absolutely non-negotiable. It means they are providing medical-grade privacy and data security within an educational setting.
Right, because a school district legally cannot integrate an outside medical provider unless those strict privacy standards are met.
Exactly.
Furthermore, they are providing active support for the upcoming HB 268 compliance deadline hitting in July 2026.
Which is a huge deal for these schools.
Right. This is a major legislative mandate in Georgia regarding student mental health infrastructure. So by partnering with MentalSpace, the school districts are outsourcing a massive administrative and legal burden directly to clinical experts.
Yeah.
But to me, the most important logistical detail here isn't the legislation, it's the accessibility.
You mean the financial barrier?
Exactly. Specialized therapies like COM and HRT are incredibly expensive.
Very expensive.
If a family is uninsured or underinsured, the out-of-pocket costs are just a total roadblock. But MentalSpace accepts Medicaid with a $0 copay.
Which is life-changing for so many families.
They completely remove the financial wall. And for families with private insurance, they accept the major carriers: BCBS, Cigna, Aetna, UHC, Humana, Peach State, CareSource, and Amerigroup.
When you remove the transportation barrier by utilizing telehealth during the school day, and you remove the financial barrier through comprehensive insurance integration, you actually give the student a fighting chance to engage with the therapy.
But there is one piece of the puzzle still missing for me.
What's that?
If the kid is using their hoodie as camouflage, and they are terrified of being found out, how do they even get into the MentalSpace system? Like, who actually makes the referral?
Ah, that is where MentalSpace's ongoing teacher consultation and staff training come into play.
Okay, tell me about that.
Remember earlier we said the teacher or the school nurse is often the first person to spot the failing camouflage?
Yes, the gym teacher or the nurse.
Right. MentalSpace trains school staff to approach these physical signs not with discipline or shock, but with informed compassion and curiosity.
Informed compassion.
Exactly. When a trained teacher notices the missing eyebrows, instead of creating a punitive, high-stress confrontation, they know exactly how to gently open the door and facilitate a warm handoff to the MentalSpace care team.
Oh, that is so much better. It transforms the school from an environment of surveillance into an environment of actual support. And the data provided in the briefing proves that this ecosystem approach really works.
The numbers are frankly striking.
Yeah.
By integrating care directly into the school, MentalSpace reports an 89% rate of improved student attendance.
Wow, 89%.
Yes. They also show a 92% reduction in anxiety, which, as we know now, is the primary trigger for BFRBs.
Right.
And they maintain an 85% family satisfaction rate overall.
It just proves that when you provide the right clinical blueprint in an environment that is stripped of logistical barriers, you can fundamentally rewire a student's future. And, well, that brings us to the end of today's deep dive. We have covered an immense amount of ground today.
We really have.
We started by tearing off the camouflage and uncovering the hidden, heavy reality of body-focused repetitive behaviors. We looked at how these are not just bad habits, but strict medical diagnoses.
Right.
We shattered the pervasive myth of willpower and explored the neurobiology of how a dysregulated brain essentially wires its own thermostat backward to seek emotional regulation through physical damage.
And then we looked at the fix.
Exactly. We looked under the hood at the clinical mechanics of habit reversal training, spotting the runaway train, and pulling the lever with a competing response. And finally, we examined how systemic, barrier-free programs like MentalSpace School are bypassing the traditional healthcare waitlists and bringing this life-changing infrastructure directly into Georgia classrooms.
It is a profound shift in how we view both mental health treatment and really the role of the educational environment in facilitating that care.
It really is. But before we sign off, I want to leave you with a final thought to chew on. We have spent all this time analyzing how the human brain can automatically, just subconsciously wire itself to seek comfort through hidden, self-harming, repetitive behaviors.
Yeah.
But we also learned that we possess the remarkable clinical blueprints to successfully rewire those exact pathways. By simply identifying the invisible triggers and intentionally training targeted, competing responses, the brain can literally heal itself.
It's pretty amazing.
So think about your own life. Think about the background noise of your own operating system. What other seemingly unbreakable subconscious habits are you carrying around right now? What automatic reactions are secretly driving your days, just waiting for you to identify their triggers, pull the lever, and finally find a healthier track to switch them onto? Thanks for joining us on this deep dive. We will catch you next time.